Thank you for moderating this session and coming. And we are using, we wanted to start immediately. We know always running late with a talk. So Sharaf is a friend and has gained an incredible experience in the use of Impella in coronary artery bypass grafting with some very unique abilities also in the setting of pump cabbage. So we will be very happy to hear from him from University of Essen. Sharaf, please.
Gianluca, thank you very much. Thank you to Dr. Tagat and Dr. Boscas again for the invitation and the consideration for this year again. So actually I thought I'm going to talk faster because my presentation used to be 15 minutes and they cut down to 10 minutes, so I have some time, so I'll talk slow again. These are my conflicts of interest. So surgical management of patients presenting with a severely impaired left ventricular function undergoing CABG surgery is complicated and associated with high risk of mortality and morbidity. We know that. We know in case of post-cardiotomy shocks that mechanical circulatory support, especially ECMO, extracorporeal life support, is considered the main MCS system used for such patients. Recently, the use of Impella has been elaborated and adopted for short-term temporary MCS. In our facility, the Impella has been used in the last 5 years in different settings. And I will tell you a story how we change our mind of thinking and mindset. We know that the Impella 5.5 have been presented in 2018, and the group of colleagues in Hamburg, Bernard and Professor Shura. Later on, also Danny Ramsey presented his first experience with the 5.5 in 2020, and also the first presentation about coronary artery bypass grafting supported with Impella have been in Cleveland, Tom Tang and the group in Cleveland, and later on also our colleagues in Heidelberg. So we also consider this kind of support. We presented our primary data last year in the International Society of Heart-Lung Transplantation with more than 30 cases with a CABG supported with Impella. And later on, we also presented our data of mechanical circulatory support in patients with the MCS using the Impella 5.5. And this year, during the AATS, we presented our data supporting all kind of cardiac surgery during left ventricular failure supported with a 5.5. So I choose cases because Gianluca asked to just include patients with isolated CABG. So I choose a couple of cases. This case especially, I consider it a mindset changer. I rated this case like 2.5 years ago. Patient was 68 years old, came to us with acute coronary syndrome and has a dyspnea at rest and chest pain unit. So they have a usual medical history, status with TIA, and have an event recorder. They have a coronary angiogram, and they see like severe diffuse three coronary diseases and chronic occluded LAD. Even though they couldn't manage to do a BCI, so they sent the patient to us, but it was late. They sent it 12 hours later. The Syndex score was a 40. These are the coronaries, the right side and the left side. And you see how diffuse the coronaries. The left side had a CX, high-grade subtotal stenosis, and the LAD is completely occluded, and the whole septum and the anterior wall is completely not perfused. So if we look at the PA, the right catheter shows that the right ventricle is still okay with acceptable pulmonary pressure and pulmonary saturations, but the cardiac index was 3.5 and the cardiac index was 1.9, and the resistance was about 1,800. We see here the left side is struggling too much because the patient has a malperfusion in the last couple of hours. But this thing is acute. It's not, he has a failing ventricle. So I thought when we revascularize this patient, he's going to make it well. So we did a complete myocardial revascularization. He has 4 bypasses. We do a usual on-bump for such patients, 60 minutes cross clamp, and after CBB, we did a bypass function test, and we initially succeeded to go out of the bypass. We checked for the flows and the pulsatility index, they are very acceptable. However, a couple of minutes later, the patient ran out with hemodynamic instability. So I thought, we have to consider something for these patients. So we should do something. But because the right ventricle was okay, I thought we're gonna do a left-sided support. But this patient, when I asked the anesthesiologist, how is the labor work of this patient, I found out that the patient has a CKMB of 353 and a troponin more than 100,000. So the left ventricular function was okay, was bad, and the right ventricular function was okay. So I decided to go for just a bailout Impella CB. So I did it over the right axillary shunt. But we use for this echocardiography as well as a fluorescence scope. So we use both of them for support. Even though the patient did well, discharged to the ICU without catecholamine support, stable hemodynamics, preserved lactate values, ventilator weaning second postoperative day, and mobilization in the third postoperative day. And finally, Impella weaning starts at the fifth postoperative day and complete removal at the seventh postoperative day. We keep these patients in contact, in touch. So we have him every 6 months, and the last 2 years follow-up a couple of months ago, he has a good preserved ejection fraction of 40%. The second case is a patient who presented to us with a subacute, I wouldn't say like an acute, but a subacute with a dyspnea and shortness of breath, and past medical history shows hypertension and diabetes mellitus. Coronary angiography shows three vessel disease and impaired left ventricular function. The ejection fraction of the patient was measured with a 24%, and the left ventricular end-diastolic diameter is about 6 centimeters. So we did the right catheter, and we see that the patient at the right side is well, and this mitral insufficiency is barely hard, as you see here. But he has a distended left ventricle and dilated, and the mitral valve is not that regurgitated. So we didn't do anything in the mitral valve, even though we did the bypass procedure, and we directly go after bypass flow and everything. We sure that the patient would be perfused well to direct protection to switch of Impella 5.5. And we didn't do weaning and the same mistake as last time. So we get in this time, we do a side cross clamp, we do the proximal anastomosis as well as a shunt. I will show a video for 2.5 minutes later, and we close the chest as usual, and we see that the patient is supported with this Impella. The postoperative management and course of this patient shows a very good results in comparison with the other patient. We could extubated him 3 hours after procedure. The first day he was immediately mobilized, and later on weaning started on the third postoperative day, and the fifth postoperative day was completely removed, and he was discharged from the ICU at the sixth postoperative day. 1 year follow-up shows ejection fraction of 35%. And the third case is more interesting because the patient is 55 years old, so we consider these patients as we have to consider LVADs for these patients when they come with the ejection fraction of 20%. But these patients come to us and we start to evaluate it differently. I will show a diagram later on. He has an ischemic cardiomyopathy. He has even a CRTD since 3 years, and the first infarction was like 4 years ago, like 51 years old, and typical history with a mitral insufficiency of grade 1 and valvular and severe reduced ejection fraction of 20%. So these are his coronaries. The right side was stented, and the stent was doing great. So we decided to reperfuse the left side and support him and see what's happening for him. This is the echoes before the operation. And this is the operative course. We did 4 bypasses for him using 2 arterial. We did a cross clamp time of 68 minutes and direct transaortic Impella, and we wean him immediately. After 3 hours was also extubated first day out of the bed, and Impella weaning a 4th postoperative day and 6th postoperative day were completely removed, and the ejection fraction have been improved within 3 months. So this is the procedure how we do it, to do transaortic Impella implantation during reperfusion. After doing the distal anastomosis, we do the proximal anastomosis, and then we do direct side clamp for both, one for the proximal anastomosis of the coronary, as well as shunt for the Impella implantation. So we see that there is enough area between the aortic valve and the shaft of the aorta, so the impella will be good supporting and away from the aortic valve, so the outflow of the impella will be above the aortic valve. This is very imminent. So after we do the graft, we tunnel it above the jugular, behind the sternum, so about 7-8 centimeters away from the incision. And the patient you see still under cardiopulmonary bypass. So in the reperfusion phase, is the patient supported, reperfused from the cross clamp of 60 minutes or 70 minutes, whatever how long your bypasses are. And then we do a wire, and we do a Bechtel, and then we implant directly. In case of transaortic, we don't need a fluoroscopy, so we just use a TEE, and we see that the Bechtel is there, and we direct shift to the impella after de-airing. So we see it like 2 days ago from our colleagues that they do it in a cross-clamped, one cross-clamp. I disagree with this idea. I talked with them about this, and we have time to perfuse the heart, and we directly wean from impella, from heart-lung machine, direct with this, starting the support of impella. Some technical support, so you don't have a lot of bleeding. And the final results will be showed directly at the echocardiography. Bella is doing well. We start support with P2 and we elevate, and then we completely wean from the heart-lung machine and close the chest. And this is how we do it today. So how's the post-operative management? I think the post-operative management is one of the most important things we do. So we start with a systemic hibernization. We talked about this like 2 days ago enoughly, and some colleagues, they don't hibernize, but we do it routinely. We wean from the ventilator. This is the good thing, because we stop catecholamines and pressure support, so we wean from the ventilator as soon as possible, and we immobilize the patient with an impella. So we do a daily echocardiography. It shouldn't be like TEE, but it's enough to do a transthoracic issue, so you can see the position of the impella, as well as you can see how the function is doing. As long as the patient has no pressors, we start with the levosimendan and stepwise reducing the impella support. And with B3, B2, we leave it for 24 hours and we completely remove the impella. But this is not a scenario for every patient. Some patient doesn't work like that. So we keep the patient in the heart failure board or outpatient clinic, and it's not working. We do an assessment for an LVAD in cases of acute coronary syndromes. So this patient consented for the procedure. She has a minimal invasive mitral valve surgery besides impella. This is the first post-operative day. She has an ejection fraction below 28%, and afterwards, after repair, it went down to 20%, so we supported her with impella. She was immediately extubated, and first day post-operative, she was walking around. And how we do explantation, this is an issue. It's not a complicated procedure, it's an easy procedure. The patient is awake. He will be having a local anesthesia. The procedure takes exactly 15 minutes, exactly 15 minutes. So we remove the impella at first. The shaft of this graft will be full with clots, so we do a flushing. We check the impella if we have any clots, and we send it for analysis. And then we flush the graft, reduce the size of the graft, and sew it closed. And you see there is a space about 7 to 8 centimeters away from the sternum. We have barely wound infections in these patients. We irrigate the tunnel with a vancomycin solution, and we put some vancomycin solution inside, so the patient, we guarantee that the patient doesn't have any infection. And it's 1 centimeter incision, so the patient is awake.
I don't do that. I leave some.
You can also do it in the ICU, but I don't favor that, because in the OR you can always react. These are not a patient, a straightforward patient. These patients have always bad ejection fraction, so you have to keep them in mind. So enough space, you don't think that the patient was intubated and doing great. So, I'm sorry. So how I use Embella? This is a question was done from Gianluca, so I did this diagram only for you. If the patient coming with acute coronary syndrome, so if he has a single or two vessels disease, you can consider OPCAB and you can consider HCR. We do it. We have a couple of patients. We do it with a off pump without the use of Embella. This is only the category of patients we use Embella in, but I didn't like check all the patients in the last 5 years how we react with them because it's a new technology. So if the multiple vessel disease, you can consider either on pump or off pump, whatever you are comfortable with. I am comfortable with doing this patient on pump because these patients need a complete myocardial revascularization. It's a cross clamp of about 60 minutes, and then you see the results immediately. If the patient coming with a coronary artery disease, chronic, it's a different setting. So you need to do an MRI or CT so you can assess this ventricle. I know that Dr. Boscas is against MRI, but these patients will fail later. They will have problems. So if he has a viable myocardium and eligible CT, you can do an on-pump protected cardiac surgery with an Embella. And if you have a viable myocardium and not eligible CT like in porcelain aorta or calcified or whatever, you can do an off-pump. You can do an subclavian Embella and do your targets very easy because you unload the ventricle. It's so easy to do. But if the myocardium is not viable, we consider the patient for an LVAD evaluation. That's exactly how we do it now in Essen. So these are some data of the isolated CABG surgery patients that we are doing in the last 4 years. So we have almost 50 cases so far, isolated because we have more than 90 cases, including other surgeries, mitral and concomitant aortic valves. We have an age of about 67 years old, and ejection fraction before the main procedure is about 27%, and 40% of the cases were in the ICU because most of them that are coming with a severe infarction. They have a CBR. Some of them, they have an MCS before, like an Embella CP and sometimes in peripheral ECMO. And they have, a lot of patients have an Intermax 1 and 2. So these patients are really, really sick and they have a huge risk scores. So we evaluate the Embella again, the ejection fraction again before the Embella implantation. It was barely below 25%. So most of the patients come for an emergency, but the elective cases doing much, much better because we plan it better. Off-pump patients, only 10% in this category of the patients because I told you I feel comfortable to do it, complete myocardial revascularization. You see the number of bypasses we do is almost 4 for all patients. And you see this Embella transposition implantation site, either transaxillary or sometimes you do it transaortic. Both are okay as long as you are comfortable with the incision and with the weaning afterwards. So when Embella is a very good question. This is what we learned. I told you, like the first case I showed, it was a mindset changing for me. We started at first with a bailout strategy, but now we completely changed our mind from being a reactive to a proactive, preemptive procedure. So we have a much, much better results for these patients, and we stopped to be a reactive surgeons. So post-operative, we have, as usual, as expected, on high-risk patients. Most of them, they are reanimated. So 4 patients had a stroke, which they were already reanimated, all of them. 30-day mortality was 28% and 1-year mortality 44%. But complete weaning from the Embella was successful in 64% of the cases, and switch to LVAD was in 3 cases, 6% of the patients. So Embella site complications, we always think Embella has a lot of complications, thromboembolic and everything. We check all these patients all the time. So we have ejection fraction afterwards, we have above 30% of the patients. Embella site implantation was only bleeding in 4 cases, and thromboembolic complications was only in 2 cases. So our take-homes, the decision to perform an MCS immediately when indicated. We do a proactive, we stop to be a reactive surgeon, so it's too late, and most of the patients have much more complications. The evaluation, the right ventricle is important, do not underestimate, and if only the left ventricle is impaired, you can consider Embella. If biventricular, you can consider ECLAS or even ECMELA, and sometimes if you have the right ventricle function is bad, you can do an Embella and also veno-venous ECMO, and finally, if you have bad flow, bad bypasses, you have to revise them. So these are some of our patients. We don't do it, as I said, only in CABG setting. We have CABG plus mitral valve, CABG plus other procedures, aortic valve also, and also valvular lesions. And these are the patients first postoperative day before they're having their breakfast before they start to mobilize. And these are the follow-ups of these patients. 2 years, 1 year, 6 months, and this the patient with the mitral valve, she thought she's going to die, and she came later to follow up. But these patients are still sick. They need our follow-up. They need a heart failure board. They need regular outpatient clinic. So to conclude, outcome of these patients is still high risk. They die, but we have to keep an eye on them. Complete myocardial revascularization is essential to allow functional recovery of the myocardium. Transaxillary or even transaortic is feasible and reproducible. My fellows do it so easy. It's not a complicated thing. And immediate hemodynamic stability is guaranteed. You can immediately wean from catecholamines and pressors. And successful weaning from the SES, sometimes you go to the long-term LVADs, and meticulous post-operative management is very, very important for these patients and mandatory. And finally, imperial-related complications are so far few, but we need more results, we need more data. That's why an international multi-center study is important. That's why we are taking a part of the multi-center international study for the Impact EU, and we included so much patients, and we are waiting for the results of this multi-center study. Thank you very much for your attention.
Thank you very much. I think since the topic is a little bit off from the others, we should allow 1 or 2 questions maybe right now, and I would like to start with asking you, why would you do protected CABG using a cardiopulmonary bypass if you have a patient that can do well with an impeller only? I mean, that would be our strategy.
Yes, of course.
And not do any aortic clamping, really?
Yes, we don't. We know that the results between off pump and on pump. This is a very, very long struggle between both. We have no bad results based on the clamp and the cardio.
Well, that I would object to. I mean, clamping is bad. I mean, for anyone objects to that? I mean, there's multiple studies that have shown that it is associated with stroke. No matter how you
Of course. I didn't say that.
Or complete or what.
So we are talking about 2 different sets, as I already said, acute coronary syndrome and chronic coronary syndrome. If a chronic coronary syndrome, we prepare the patient at first. We do an MRI, we do a CT scan, and we can decide which set we would like to have. If the patient is eligible for a normal bypass procedure, we do it with Embella, so we can implant well, we don't have perforations, we don't have a manipulation in the heart using the Embella. We do it also with off-pump settings, but if you have a patient with acute coronary syndrome, you don't have much of a choice. If you have only one vessel disease, so you can decide you want to do it on off-pump, without Embella, without anything, even if you have bad ejection fraction. We have a lot of these patients, and we have patients who are really failing ventricle, lower than 20%. So you do an Embella, and I do it on off-pump, one bypass, and that's it. So both options are there. This is only the patients treated with Embella. So if we check all the register we have with the patients not treated with Embella, just off-pump alone, or just doing without bypass alone, we will see different results.
And what is really your threshold to say, okay, I do a protected CABG in an elective setting?
Yes,
patient comes in, ejection fraction, as we all know, is a very poor parameter for everything.
Exactly.
Including to know if a patient does well or not after an operation.
Very good question. Thank you very much. So that's why we actually now in a study called the Impact EU. I think your center is also a part of it, and Evgeny is a part of this study. So we check more parameters than this. So if the patient coming with a coronary artery disease, chronic, we do an MRI, see if the myocardium is viable at all. So if he's viable and we are expecting improvement of this myocardium, so we do a bypass surgery, either on pump or off pump. Whatever you do is right. Main thing is, as Gianluca said, you have to be comfortable with the procedure. If you are not comfortable with the procedure and you want to do 5 bypasses and you will feel like the Embella is inside, you have to, we talked about like 2 days ago, you have to remove it, put it back, and sometimes you need to show the CX in the deepest point, and you have to remove it back, so you have an aortic regurgitation during the anastomosis, which is very, very uncomfortable and hemodynamic unstable for the patient. So I prefer to do a protected cardiac surgery on bypass, so I don't have these all problems when the patient is eligible. When not, you can do it in off-pump setting. But I go transaxillary. I don't do transaortic off-pump.
Transaxillary.
Exactly.
Yes.
So I have far away place and I can remove the heart as well.
Dario.
Yeah, Dario Candura from Leiden, the Netherlands. Wonderful presentation, very interesting topic. Probably it was me, but I missed on your presentation any form of a cardiac output measurements, Swan-Ganz.
Yes, we do. We do a right side heart catheter for each patient, and we can decide if this is enough or not. And I told you, like, one of the cases, 2.5 years, I was like considering he has like 20% AF. I said, like, when he has a bypass flow was great. I weaned from the bypass, and then he has an hemodynamic instability. We were close to reanimate him. So I changed my mind and changed my kind of thinking about these patients. So
the reason why I was asking that is that I have the feeling that most of these patients don't really need the 5-liter flow that Impella 5.5 can support.
Yes.
And maybe it can also go well with just a percutaneous Impella.
Yes.
Do you have any experience with that?
yes, the good question is, how many patients do you have, or do we have in acute setting? They have acute coronary syndrome, and you go to the OR, you have a good feelings, and you just start to prepare the grafts, and the anesthesiologist start to screaming, the patient is completely down, you have to start resuscitate, and you have to put him in the heart-lung machine. So it's not an unusual, it's not a rare thing, it's something, it happens, especially in acute problems. So you have to have plan B, and usually I had Bella or MCS as a bailout strategy, and now I changed my mind because I have different results. I have a good results.
Please, Krista.
Dear Sharaf, great presentation.
Thank you very much.
2 comments. First, on the myocardial viability, I just wanted to say that the STITCH trial showed that you have a benefit from CABG, even if you don't have myocardial viability. You have to keep that in mind.
Of course.
When deciding. And the second, want to share our personal experience that at least in acute coronary syndrome, doing Impella-protected CABG without heart-lung machine in our cohort seems to be very beneficial.
Yes.
And produces better results. I have the same feeling about elective patients, but I'm for sure for patients who come with bad ejection fraction in acute coronary syndrome, going on pump in our cohort seems to be not the best choice.
Cristo, tell us a little bit technically how you do it off pump in your center, off pump Impella. You put the Impella via axillary day before, or a couple of days before. Patient that comes in, moderate bed targets, low EF,
we had
AKI.
Different cases. This year, 2 patients came with lung edema, acute coronary syndrome. We put an Impella axillary, waited for 1.5 days, and then operated as soon as they stabilized on Impella. On the rest of the cases, we did 11 cases of off-pump Impella-protected CABG. The rest of the cases we were elective or without cardiogenic shock in acute coronary syndrome. And we did, in all cases, auxiliary approach, not going to the aorta. And I usually implant the Impella first and do the sternotomy, or if I have problem with passing the valve, I may do the sternotomy and help with the finger by pressing on the valve to insert
Sounds good.
the wire. Yeah.
Thank you. Last quick question. Thank you.
John Castro from Minnesota, USA. I've only done right axillary 5.5s. So could you give some pointers on how you exit the graft in the neck on a direct aortic cannulation?
Yes, we go, there is 2 kinds. We discussed this earlier. Actually, there is 2 categories. Some colleagues, they immediately shifted from the left side under the sternum, but they do it from the right side next to the jugular vein, actually. So it's direct 1 centimeter, 10 centimeter farther with no kinking, so you can easily mobilize the Impella afterwards. It's behind the sternum. So you go with your finger behind the sternum up there, and you can give a small tunnel, and you can have the shift at first, and then you put the sheath, the auxiliary kit, and then you can do as usual as you do. Some colleagues do it from the left side, also in the USA, but I think it's very competitive, and if the patient needs a BTR or tracheostoma later on, it will be very difficult. So I never do this. I never cross the midline with it.
Thank you so much. We can go to the next speaker. We call Dr. Perrault, minimal touch vein harvest with hydrodissection. Please.
Well, thank you so much. I apologize. I thought I was at 2 o'clock.
No.
I was waiting for the business meeting to end, so I guess if I'm part of the society next year, I'll know when to start. So I'd like to thank the organizers and for putting together a great meeting and for inviting me. We're changing gear from Impella, obviously. These are my disclosures. The only one relevant to this talk is Artrex. So if you've missed Dr. Gallagher's talk yesterday morning, he's actually the inventor of the hydrodissection for the saphenous vein, and he'll be on hand because I got to catch a flight, so if you have any questions, he's the man. We actually submitted this small paper as a research letter to circulation a couple of weeks ago. So as a disclaimer, I was trained, believe it or not, in EVH myself in 1999 with the guided system. I've performed most years about 200 myself because we don't have that many PAs. I have published on the technique, the patency, the complications. I've also used radials. And as I said, I got to go quickly. I was trained with this instrument, which looks more like a weapon than something to harvest the vein. This is way back. It's more subtle now, but you get the message. So I've published, as I said, and we did a QCA study way back in 2004 that we published looking at the difference between open and endoscopic. And it was a one-year study. We didn't see any difference back then. So we know vein graft failure is still a problem. It's a complex challenge, but there is a window to act, and that's the day of the operation. So it remains, we know that there is a clinical impact. You see the dotted line on the top. If you have vein graft failure, you will have more death, MI, and revascularization. We need to tackle this. This is a slide that I borrowed from John that was presented at the AHA in November 2021 that shows the pathophysiology of vein graft failure, but we know that there's going to be failure in the first few months, about 15%, and the classic figure is 50% at 10 years. This is results from that trial, and you can see that vein graft occlusion or diffuse disease was high in both supported and unsupported vein grafts. At this meeting a couple of days ago, a group from Shanghai showed once more, association between early graft failure and subsequent clinical outcomes, and I think the failure rate at 1 year was still 23%. So it's a no-brainer. What would you have? This incision or this one? So we need to find a minimally invasive solution to harvest vein grafts, aside from all the arterial grafting that is necessary, obviously. So this is results from the Swede graft that was presented at EEC a couple of months ago. So the group originally from Sweden, where SUSA put together the open technique, showed in a randomized trial at 2.8 years that there was no benefits of the no-touch technique over conventional. And obviously the complication rate for leg wound infection was greater than 50%. So there remains a need for an endoscopic no-touch saphenous vein graft harvesting, and it's been explored. This group is from Japan, and they introduced a no-touch technique in 2018. They refined it slightly to publish an innovation in 2023, but it is not a pure no-touch technique. You still handle the vein quite a bit, and that's suboptimal. Yesterday, there was a very interesting EVH symposium that I attended, and interestingly, Richard Vitale, a PA, had this topic, which he discussed partially. What will it take to make endoscopic conduit harvesting safer and globally adopted? We think we may have a solution. This is a review from Stephen Freems in 2021, How to Improve Vein Graft Patency, and you can see the different solutions, meaning there is still a lot of work, and I recommend this review for you. There are 7 major problems with EVH, maybe more, but the 7 main ones are blunt trauma. Obviously, there's a steep learning curve. There's thrombi that can form on the endothelium. If you eperonize, there can be bleeding, could be spasm, thermal spread from the bipolar cautery that will become a nidus for intimal hyperplasia, and obviously, there is a toxic, acidic environment of CO2. So what's needed? Something that is minimally invasive, no touch, that will solve the major problems and end up with excellent long-term patency. This is a trademark procedure, minimally invasive, no touch procedure, and we believe that this, and we'll show you, avoids the 7 major problems with EVH. By the way, this obviously can be used with the radial artery. Hydrodissection is not new. It's been used in the plastic surgery field a bunch, either for mastectomy or for freeing the median nerve, or also for dissection. This is where Dr. Gallagher got the idea to dissect out the fragile neurovascular bundles for flaps, muscular flaps. It's been used also, as you know, in cardiac surgery to hydrodissect the left thoracic artery, and this is from Australia in 2005. So I'll stop the video quickly here if I can, and I can. Where's the mouse? Okay. Okay, I'll let it run. Basically, you are in a fluid environment. The black catheter that you see on top here is the hydrodissection cannula. It is away, so further out than the scope. The liquid is infused. Right now it's a plasma-like A with papaverine and heparin, locally delivered, and the liquid follows the plane of least resistance and opens up everything, so you have the side branches. You're not touching the vein at all. Then you just use bipolar cautery, same as usual. That's the principle. So our initial study is 17 patients with the MIN technique compared to 7 patients with standard EVH with CO2. And so all the 24 patients had samples that were harvested for ENOS assay. So 24 open, no touch, 17 MIN, 17 with CO2. We did ENOS assays and scanning electron microscopy. If you look at the baseline characteristic, this is 3-vessel disease, low risk. You can see that the mean age is about 70, diabetes in about 50% of the patients, so pretty straightforward. We did do a comparison between the patients that had the ENOS assay to make sure that the risk factor for endothelial dysfunction were similar, and actually you can see that they're completely comparable. In fact, the ENOS patients on the MINT side are slightly older. So this is standard histology. We just did MINT and no touch. And you can see that in the MINT there's quite a bit of perivascular tissue, same as in the no touch. But this is the most important panel. So you can see here on the right, top right, the scanning electron microscopy to a magnification of 1500, which is rarely done. You can see the perfect cobblestone appearance with the MINT technique, something you don't see with EVH or our no-touch technique. The most striking thing here is the ENOS activity assay. You can see on the top panel that there is 3.4-fold higher ENOS activity with the MINT technique compared to the no-touch and the EVH. Now, this is important, and just a month ago, Mario Gaudino published in Circulation that perhaps the reason for recent improvements in saphenous vein graft patency was increased nitric oxide availability. And this is the 2 examples he gave. The no-touch that we know with perhaps secretion of nitric oxide with the perivascular adipose tissue, and the composite graft that the Koreans use that would give the ITA produced nitric oxide and prostacyclin. This could explain long-term patency. So in this meeting, no earlier than 2 days ago, Dr. Kim, a pathologist from South Korea, showed that in explanted hearts that had cabbage before, 20 years before, that the patent grafts that were pristine had increased endothelial nitric oxide synthase expression in the endothelium and also in the vasovasorum. So 1 + 1 = 2. You have normal endothelium coming out of the OR. You have, if you control risk factors and you do adequate secondary prevention, you will have a good long-term patency. So we believe the MINT procedure is a unique, game-changing novel approach. It's specifically designed to address the 7 problems, to prevent endothelial damage, prevent obviously structure and function. We believe it will increase safety and quality of conduits, and it will increase adoption, which is variable across the world, and it will flatten the learning curve because you don't have trauma to the vein. We believe it's going to increase market penetration, and it's amenable to ORs across the world in a relatively short time lapse. We probably could imagine that in the future, the MINT in the fluid environment could be combined with endothelial damage inhibitor solutions such as Durograph or other pharmacological agents, and would be the ultimate strategy for EVH or endoscopic radial harvesting. So the take-home message, EVH with CO2, toxic environment, less nitric oxide. The MINT in an optimal fluid environment will increases nitric oxide and perhaps patency in the long run. This is, so we're actually looking at, we're doing MD-CT scanning of the patients that are 1 year out, and we're looking forward to publishing and presenting these results in the near future. Thank you so much.
Thank you very much. An interesting technology, which hopefully improves the outcome with vein grafts as long as we still need them. You were mentioning that it's more than one factor that determines the long-term patency of vein grafts. One is certainly the harvesting technique, but also the question whether we have any means of protection. So you were mentioning Duograft as one possible option. There's others. And dilatation of the graft. I mean, that is something that we infrequently still see. I mean, that is also part of the concept, I guess, that we abandon this technique completely.
Oh, absolutely. I mean, I do, in other talks, I have all the maneuvers that should be avoided. And it doesn't take a very long time to ruin a graft on the day of harvesting and on the day of implantation. And distension is another sin that you have to stay away from, that's for sure.
So also, how long can a graft actually sit on the table? I mean, that's also something that people tend to do. I mean, you could keep it inside though as long as possible and just take the pieces that you need. Absolutely.
I have a classic slide from 1984 where you actually have a pumping of blood continuously into the vein until it is grafted. But the same could be, we've had the discussion with David Taggart before, you know, the vein would sit in the pot on the back table for, you know, as long as the arterial grafts were not harvested. And now we try to minimize ischemic time, and there is basic science that shows that evidence for sure.
Please, from the floor, Sebastian.
Yeah. Thank you for your presentation. I have a question. Did you, before harvesting, when you cut out the vein, did you took some part to see in each patient what was the enos activity in those patients before harvesting? Because it could change from patient to patient, even though the comorbidities are the same, but varicose tissues, etc., etc., etc. So it could make a difference between those patients.
Yeah, so the 17 patients, we did the MINT and then harvested in the mid segment. So 30 centimeters in the middle, then you had two pieces.
After the harvesting?
After the harvest. The no-touch also was done at the side of the incision, yeah. And EVH after, obviously, the harvest.
In the MINT, you didn't check out before harvesting, took part before starting harvesting and see what was the
would be interesting, but what if you need that piece, you know, it's, I don't think it makes, I think we want to know the influence of the harvesting technique on the enos expression. So I get your point, yeah. But, you know, in a technical fashion, in a logistic fashion, not easy to do necessarily.
Because we did also a couple of patients, the pathomorphology, we also do EVH. I think in the EVH, its main problem is experience. The harvester should be really experienced. However, we did not see, we took out before harvesting a piece of vein or radial and see before and after, and basically it was the same.
Right.
But we used the HemoPro.
It could be, but that's what we use. This is a modification of a commercially available. We've tried different systems, and I mean, some of them work better than most, but the key here is because you have such great visualization from the get-go, you're not touching the vein. And, you know, it's amazing, and I wish I'd known that 25 years ago, but it's amazing how all the planes open up, and you don't need to ram the vein, you don't need to twist it, there's no torsion. We don't do stab and grab. That's another sin. So I think that it will increase adoption because the learning curve will almost disappear.
Well, thank you. Very interesting. Thank you so much.
Thank you, sir.
Our next speaker is Dr. Nicholson, with Dr. John Pascas speaking about extreme technique for the management of CTO and by PCI and surgery. You are giving this lecture.
I am being promoted to being an interventional cardiologist. Dr. Nicholson had to return to Emory, and I have some of the slides. So these are my disclosures. His were different, and I'm going to show one case for Bill. This is a 70-year-old gentleman with multiple comorbidities and severe multilayer in-stent restenosis with a normal ejection fraction. And there's a relatively normal right. You can see the full metal jacket in the LAD, sluggish flow in that LAD, positive IFR. And apparently he used multiple interventions over multiple time intervals in March of this year, May of this year, and July of this year. Different interventional tools to try to get that reopened, but always with recurrent Class 4 Canadian Cardiovascular Society angina. So then he planned to ablate the calcium and the pre-existing stents with progressively larger burrs, beginning with a 1.5 millimeter burr and advancing to bigger burrs, but unfortunately they had a no reflow phenomenon, which they treated with intracoronary adenosine and nitroprusside and some other fancy microcatheters, and managed to use IVUS to guide this, avoiding a dissection, but documenting severely calcified multi-layer in-stent restenosis. Further rotational atherectomy with a bigger burr resulted in worse no reflow. Medical management, more balloon angioplasty, more microcatheters, but also still with a no reflow problem. Still documenting no edge dissection, improving the stent expansion. Transferred the patient to the ICU. They had anterior ST elevation and pain, and brought the patient back to the cath lab to insert an Impella through the groin, Impella CP, to decrease the afterload. And basically took the patient back to the OR the following day and repeated angiography and worked on that with more catheters, ultimately yielding a good result. So very persistent work in difficult circumstances with techniques and technologies that Dr. Nicholson discussed a little bit earlier. But I think, you know, exemplifying that there are some extraordinary technologies that very skilled and aggressive interventionalists can use, but the longer-term outcomes are challenging, and this patient had some short-term challenges. But he ultimately went home 3 days after that, free of chest pain. I don't have longer-term follow-up. Interestingly, the ejection fraction was not significantly diminished. Looks like there is a bundle branch block, though. Okay, so what are the surgical alternatives? I'm going to talk about coronary stentectomy, but beginning with coronary endarterectomy. This is a paper from 1986, the year I graduated from medical school. It's by Denton, Cooley, and others, documenting 30,000 coronary bypass cases over a 14-year period in which 12% of those patients had a coronary endarterectomy at the time of their CABG. Interestingly, those patients who had endarterectomy had about a twofold increase in their early mortality, but late mortality among survivors of hospital stay was not different between groups. This is us doing open endarterectomy of the entire LAD. It is certainly a doable procedure in very selected patients. We do it with great attention to detail in a bloodless field. There's the endarterectomy specimen on the right, and I don't seem to have a pointer. I do have a pointer. And you can see that it's very long open endarterectomy, and then the traction portion down the side limbs provides outflow. You can see also that there are multiple small diagonals and multiple septals that are carefully endarterectomized as well. And then this is all reconstructed with a very long spatulated skeletonized mammary, creating what we consider a neo-LAD. And I say that because we don't just put it on the top. We actually very carefully consider how we rebuild the LAD. And I did that after reading this interesting paper from the Indian Journal that talks about managing very diffuse LAD disease by an onlay which is intentionally sewn deep into the recipient vessel, excluding plaque in this case. This was not an endarterectomy case. But the concept is the same. The idea is that we rebuild the neo-LAD by taking stitches into the endarterectomized adventitia of the LAD. Those stitches are very deep, and they basically exclude all of the LAD adventitia except that which provides inflow to the septal perforators and to the diagonals. All the rest of that thrombogenic tissue is excluded from the circulation and replaced with this hood or roof that is made of the spatulated ITA. So it is a neo-LAD that we're creating. We're not doing just a coronary bypass. So coronary endarterectomy is not very common, but in the STS database, in this recent publication, about 3% of patients who have coronary bypass also have an endarterectomy, the most common target being the LAD. Just as was the case a generation ago, operative mortality is about 2x for patients who have endarterectomy compared to those who do not. And of course, there's lots of discussion about which came first, the chicken or the egg. Is it patients who need an endarterectomy that have a higher mortality, or is it the fact that you performed an endarterectomy that which is responsible for the doubling of mortality? In any case, after leaving the hospital, survival is comparable between groups. So a stentectomy is basically an extension of the concept of endarterectomy to patients who have a full metal jacket. And we rebuild it with this very long onlay patch. Again, we think of this as a reconstruction and not a bypass. I did not invent the concept of stentectomy. I learned about it from Shurichiro Takanashi, who has been a speaker at our meeting in multiple years. And he's now done a little less than 20 stentectomies, and I've done 12. So between the two of us, the total world experience, to my knowledge, of full-length LAD endarterectomy is a little under 30 cases. This is my first case, referred by Dr. Sharma in New York, and a typical patient, well-preserved ejection fraction with a full metal jacket of the LAD and truly debilitating chest pain. He literally couldn't get from the bed to the toilet without angina. And here's why. And I think he had 14 stents in his LAD. It was not quite the indoor record, but pretty close.
Look at this.
And here's the intraoperative image. There's the LAD. Apex is here, base is here. You can actually see some of the metal glistening under the headlights. There's a skeletonized ITA. We open the LAD distal to the stent, so we're at the true apex. And as I thought about this operation and talked about it with Shurichiro, I became convinced that the key was to get into the right plane and stay in it, and never to leave a spot where the adventitia was actually removed. Right? This is an endarterectomy, not an LAD-ectomy. We want to leave the adventitia intact and preserved in the heart. So we identify the lumen first, and then cut straight down on the 12 o'clock midline of the LED, straight onto the stents. And I wore out several 15 blades. I can tell you that cobalt chromium is much stronger than stainless steel. So it dulls the blade. But we cut down on the midline as far as we can go up the LED towards the base of the heart. Then we get into the right plane, taking reference from the point which is not stented and being absolutely certain that we're in the right plane. We start in the right plane and we stay in the right plane. If there's any doubt, do not go forward. More force is not the answer, as I teach my residents. I did have a colleague in New York who, after seeing this video, decided to do it. And I was told by the fellow that that resulted in an LAD-ectomy and a mortality. So you've got to be sure you're in the right space. The side branches are the outflow of the LAD. The purpose of doing this is to provide flow to the septals and diagonals. And again, you can see in this case, we have a nice glistening adventitia left behind. And we carefully develop that plane. This is not a quick procedure. This is edited video. We've also excluded the audio portion for the sake of propriety. Distally, it's a traction endarterectomy as far as we can go. By the way, these instruments are called the, in my world, they're called a micro-neuro kit. It's actually a neurosurgical instruments. I have no idea what they do with them, but they work great for this purpose. And you can see that's truly around the corner. That is a particular moment where we wanted to be sure the audio was not reproduced. Once we get proximally, obviously you don't want to end up at the first septal perforator. You certainly don't want to end up at the left circumflex. Typically, these have multiple layers of stents very proximally, and this is actually the wire cutters from our emergency reduced sternotomy tray. No other instrument would cut all the layers of cobalt chromium. A pair of heavy Swede scissors, though, will actually do it too. We clean up the edges. We took a picture. You can see that the LED endarterectomy is about 9 or 10 centimeters long. There's a specimen, a little longer because it goes around the corner. And there's our LED IMA target. So as my grandfather taught me, measure twice, cut once. You don't have any extra ITA to work with when you're going all the way to the apex, so you've got to cut it carefully. Then we incise it. This can't be spiraled. It has to be straight down one side of the artery. So that's a consideration to get that right. And then the anastomosis is done, we do it with either 7 or 8-O-proline. The bites are normally placed on the conduit. This is very highly magnified, as you can see. It's a normal ITA. It's not a femoral artery like it looks like in this. The bites on the recipient side are pretty deep. We want hemostasis, and we want to be able to exclude as much of that artery as we can. And now here you can see there's diagonal septal perforator, there's 1, 2, 3 septals. The bites are going to not occlude that, but they're going to exclude everything else. Again, we want to build a neo-LAD, and this is a slow procedure. This takes 30 minutes to do this distal, at least, and it takes typically 2 full lengths of 8-O-proline. And once you finally finish that, it ought to look something like this, or we think this is how it should look. And we measure the flow. In this particular case, that was a flow, good numbers. Postoperatively, obviously, we're concerned about thrombosis of the graft, which could lead to a large anterior MI. I think that risk is mitigated if you're also bypassing a ramus intermedius or a big diagonal separately. I think that there's some help there. I'd actually like to bypass if there's a occluded PDA or a tightly stenotic PDA and you're grafting that as well, then we can hope that you'll have some redundant supply through the septal perforators in addition. We use DAPT on arrival in the ICU along with sub-Q heparin, and then the next day we start triple therapy. There's no science, no randomized trial to this. The Eliquis or Apixaban is 2.5 milligrams BID for little people and 5 milligrams for big people. I can't tell you whether this is good or bad. We've done 12 this way. No one has acutely thrombosed their graft and no one has been taken back for bleeding. Maybe this is the sweet spot, but it's truly empiric. We repeat the cath or CCTA at 6 months and a year and then adjust medical therapy accordingly. Here's this particular patient's 6-month cath. You can see that the outflow to the septals and diagonals is already pretty robust, and the Neo LED looks pretty decent. You can see a little irregularity in it, but it goes right to the apex that we endarterectomized. And here's the 12-month angio. Looks a little bigger, and the outflow is a little more robust. It looks a little more uniform. This is another case more recently. Nice. Different kind of camera system, as you can see. I'm going to kind of skip through this in the interest of time. We actually did it exactly the same way.
Because I mean, I perform only I almost think that
again with a set of neuro instruments. There's the core of layers of stents, intima, and media, leaving the adventitia behind. If you're not sure of the layers, become sure. Stay in the right layer. I keep saying that to myself as I'm doing this because I think I don't know how you would fix the problem if you take out all the adventitia or even a section of adventitia.
No, it's not necessary.
So here's, you can see we're giving retrograde blood cardiopegia. You can see it coming out of the septals and diagonals.
Me too.
And now we're measuring our conduit. We're going to cut it and rebuild this LAD appropriately. And again, it's a lot of stitching. Trying to get around the corner here. And we're finishing it up. Checking for hemostasis, and that's off bypass. This is another specimen, again, stem to stern, full Monty endarterectomy. That one we had to rebuild with a radial artery. And I can't remember at this moment why we didn't have an IMA to use, but we didn't. And so this one was rebuilt with a radial with inflow from the aorta. And it worked. So I think patient selection is an important component of this. These patients, shouldn't be having occasional angina. These are people who have no further options and their life is miserable because we're putting them through an operation that is frankly untested. I think we want to know that there's viable myocardium, but profound angina is a pretty good indication of viability. We'd like to have patients who have bad angina and bad coronaries, but not bad comorbidities. So really frail people having a high-risk operation, that's a prescription for problems. We want to do this for patients who have a total or subtotal occlusion of the LAD. If there's a pretty big residual lumen, then we would expect that an acute failure of that graft would lead to a big MI. If the patient already has CTO, then in some sense, you know that the patient is likely to survive, even if the graft closed. We're enthusiastic about cases where we can graft a significant diagonal or ramus independent of the LAD, believing that that may mitigate against risk. And I think I should add PDA to that line in the slide. I'm happy to talk to people about cases that might be referred for this. I do not encourage this as a general thing. I don't think this is something we should all be doing. It is truly experimental and obviously very high risk. But I'd be happy to talk about patients or receive patients for it. We are very selective about which ones we operate on. Thank you very much.
Fantastic presentation. Any question from the audience?
Yes. What do you do with the proximal left anterior descending artery? Do you close it, or you? I didn't understand.
We did a little bit of traction and then cut the specimen, and it retracts up under. It goes back under the adventitia of the LAD at that point. You simply have to cut it. It's typically got 2 or 3 or 4 layers of stents, and you're chopping through these with a metal instrument, and then it slides back under, and you sew the adventitia, and I presume that thromboses.
Yeah.
Let me ask you, if you left more tissue for what it was left for the LADA, do you think the late angiography would be a larger new LADA?
Interesting question. I don't know the answer to that. You're advocating, oh, don't take such deep bites, John. Just leave the adventitia there, and you'll end up with a bigger neo-LAD. And I was making an intentional exclusion of that tissue, believing that it would yield a less thrombogenic situation at the completion of the surgery. My biggest fear about this is acute thrombosis of that graft. So I'm okay with that result, that angio result. It looks pretty normal. It's not very small. It's not very big.
I agree.
But I'm believing that that's better than having even a small incidence. You know, knock on wood, so far we've not had an acute thrombosis of the LAD graft. But I'm very fearful of that because, you know, fibrillation in the middle of the night in the ICU is a bad thing.
Dr. Pascas, no, please, go.
Just another comment. I didn't do stentectomy, but I did very large opening of the LADA, and I used the radial artery to open the new LADA, and I extended it to the PDA, and I got the left internal thoracic artery over that, and with nice results. So that's what I showed you in the poster on Friday.
In PDA and coming back. Interesting. Please.
How distal is distal? I mean, how far do you go, or how far proximal?
I would say that we're, in the 12 that I've done, it has not actually been stented around the apex. They always seem to stop just before the apex. I'm not sure why. Maybe there's a force field there. We therefore are able to get into the true lumen at the true apex, which is reassuring to me. Obviously, you have to harvest enough mammary artery to reach to the apex, or you're going to do, I think with one I had to, it didn't reach, so I did a free graft off a piece of vein on the aorta, so the lita was disconnected from the subclavian, put on the ACIN aorta, and then it would reach the apex. This one I showed you with the radial is another way of doing it, but I think if I remember correctly, my resident buggered up the mammary and we had to do the radial. But distal is as far as you can go, but you've got to be able to cover it.
Thank you.
And there's no going back. Once you open that thing, you've got to cover it.
John, fantastic presentation and video. We're fortunate in the UK that our cardiologists are not as crazy as other places. So we rarely, I don't think I've ever seen a full metal jacket. I've certainly seen cases where I've done these localized endarterectomies, maybe over 3 or 4 centimeters, but certainly not down to the apex.
Wow, that's interesting, because I'll bet you there are many hundreds of people whose angiogram will look like that in America. Maybe thousands.
I've never seen it in the UK, and it's definitely not part of what cardiologists would do. But the other way I've done these, if it's a segment over 3-4 centimeters, I'm happy to put on the IMA as an onlay graft. But the other things I've done sometimes, and I don't know, as you say, there's no real evidence for this, is what I've also done is just done it with an onlay vein graft, because it's much easier, much faster to sew. And as you say, the key bit is make sure you don't disrupt the adventitia. But what I then do, if I do a vein graft, I then plug the IMA into it, because it's a pretty fast procedure and technically straightforward. And again, whether it's luck or a bit of physiology, I'm not sure, but I haven't seen an acute thrombosis with that technique. And I think probably one of the reasons is explained by the work Ki-Bong Kim has done in the Save Rita trial, that he has these superb, when he attaches a vein graft to the IMA, the long-term patency is remarkable. So I wonder if just plugging that IMA in does genuinely protect that onlay vein graft.
It might do, and certainly the vein patch with arterial inflow is well described. It goes back a long, long way.
Yeah.
I have figured that if I can do all artery, I'll just do all artery.
Sure.
That's been our norm and kind of our mindset. It also produces a relatively physiologic or anatomically normal kind of size when you're done. Maybe I think that the endothelial cells of an ITA are more likely to crawl onto that adventitia and set up shop and rebuild a neo-LAD made of arterial adventitia and endothelium, arterial endothelium, more so than a vein would, but I don't really know if that's physiologic nonsense or not.
But as you also intimated, when you look at the Dr. Takanashi's series, he shows very clearly that at 1 year, these long mammary arteries remodel themselves. Yeah. So they actually begin to look like the native vessel, which is what you're intimating, that you're building a new LAD.
Exactly.
Anyway, congratulations, fantastic results and fantastic video. Thank you.
Thank you. I think John Lucas shot the video of that first one.
John, to add complexity, I did a few of these cases beating heart with 2 stabilizers. Yes. So is that something?
You and Chirito are alike. I think he did half or so of his off pump with 2 octopuses.
Yes, because you then don't have the ischemic time.
Right, you don't have the ischemic time. Fair. And I think it would be a reasonable thing to do if it's truly a CTO. Because that long anterior wall ischemia doesn't exist. It's certainly no worse than it was before the patient went to sleep. I think you'll acknowledge that that probably adds an element of difficulty to it. It's probably harder to do it that way. And as much as I have spent a lot of time in my career doing off-pump surgery, this step towards standardizing an operation like this, I thought I would start with an on-pump approach. I don't think there's anything wrong with doing it off-pump, but being able to really clearly see exactly where that layer is, with no blood in the field and no motion. I'm just terrified of putting a significant tear or multiple tears in the adventitia during the endarterectomy part, and then rebuilding it. That's a problem. I don't know how you're going to get around that and expect hemostasis and not to have a clot. As I said, we had a colleague at Sinai who saw this video 2 years ago and did one, and that patient didn't get off the table. So that's not what I want to do.
That's not nice.
Dr. Boscas, here. Thank you very much. This was one of 2 comments I wanted to ask because I saw a video from you doing it off pump like Professor Takanashi, of course, but I now have the answer. The other question is regarding to your regimen post-operative. You know that we do it. We present our data earlier here in ACC, and we just use dual antiplatelet therapy. We do also multiplate testing and the third postoperative day to see the efficacy of this dual antiplatelet therapy. But I saw that you are increasing also on NOACs as well. Don't you think this is too much aggressive? Do you do it with a stentectomy only or with endarterectomy? What's your comment on this?
Great question. I don't know how much is too much anticoagulation. And clearly, stent thrombosis and probably graft thrombosis is not primarily a coagulation problem, it's a platelet problem, at least in the first phase, right? It's been clearly shown that anticoagulants per se are not indicated to treat stents, right? The cardiologists do not give people Eliquis for their PCI. They get DAPT in different flavors of DAPT, but they get DAPT. This is a little different. It's 10 centimeters of a raw surface feeding the anterior wall. So I have been very concerned about acute thrombosis, and everything that I've designed about the way I do this operation is to avoid that catastrophic problem. It's to avoid the phone call, Mrs. Smith is fibrillating at 3 a.m, because I know by the time I get to the hospital, Mrs. Smith will be dead.
Okay.
Thank you. Well, Dr. Pascas, you can stay in proximity of the microphone because your next talker as well with Dr. Cipollini and from the London School of Cardiothoracics. They will present their experience on how to teach off pump and how to teach coronary bypass grafting in general. Please.
Super. I have a very brief introduction here. So these, again, my disclosures. I think teaching off pump is first and foremost to have the student or resident understand this concept. That safe, reproducible OpCab is all about creating essentially the same visualization and stabilization that you have during on-pump cabbage, maintaining stable rhythm and hemodynamics. In other words, preparation is the game. The sewing, once you start sewing, should be routine. And 2 slides about how we get there. Basically, we have to not compress the heart as we rotate it to expose coronary targets. So we divide the diaphragmatic muscle that tethers the right side of the sternum. We open both pleural cavities widely. We're typically harvesting beta anyway, and I think it makes it much easier for the heart to rotate, especially if it's a large heart with a low EF and we're doing multiple lateral wall grafts. Sometimes we'll pace the heart faster in order to have it be smaller. Bilateral transverse pericardiotomies are performed at the level of the diaphragm towards but not into the phrenic nerves. We prop up the right sternal border under rolled towels, and we place deep pericardial traction sutures, which we have in the last years included a ribbon gauze, as Dr. Sargent taught us to do. We want to rotate the heart and not compress it using that ribbon gauze in combination with the so-called apical suction devices, which we place off apex quite routinely. The pericardial traction sutures are never pulled up on both sides simultaneously. We think about the 3 territories of the heart somewhat differently. To rotate to expose the anterolateral and lateral wall, we let the base of the heart down and rotate the apex under the right sternal border if possible, or make it vertical. To get to the inferior wall and posterior inferior wall, we elevate the base and point the apex towards the ceiling. And to do the RCA or some of those acute marginal oblique PDAs, we let the heart down in the chest and just rotate the acute margin using the starfish. I'm going to show a little video of the placement of what I call the Sargent stitch, because this is posteriorly, it's placed between the left inferior and right inferior pulmonary veins, closer to the left, as far back up under behind the heart as you can. And then we tether this ribbon gauze down there. And that allows us to have an end result that looks something like this for exposure. And you can see the gauze is rotating the heart in combination with the starfish. We have beautiful exposure of the anterolateral wall and the lateral wall for grafting the targets that most people generally think of as most difficult off pump. It can be made easy, and you want to make it easy before you start sewing. I think in teaching OpCab, mentorship is important. I'm very proud that Gianluca, I had a chance to mentor Gianluca. In the center is a guy named Rosati, Carlo Rosati, whose work was cited in one of the earlier presentations today, and on the right is Yoshi Sato, my present coronary fellow at Emory. We still fundamentally have a Holstedian apprenticeship model for training surgeons, and that applies to OpCab as well. What do we let them do? Well, we start by letting them harvest, placing that deep stitch. The first anastomosis we let them do is to sew the reta to the radial in the eye graft, because that's up on the drapes, it's well lit, it's immobile, and it's disposable. If they mess it up, you can just cut that out and do it again. The first distal anastomosis is typically a piece of radial artery that has inflow from the LAD, and it's from the ITA rather, and it's going to the diagonal. The second that they get to do is the LED, the ITA to LED anastomosis. Why these two? Because I can see them. I can see them when the resident's sewing. Then the distal anastomosis to the PDA, which is usually an elongated right mammary. And then the radial artery to the OM, which is typically coming off the left ITA. The ramus intermedius is a harder vessel to visualize than the lateral wall, and it's usually intramyocardial, so that's the last distal they get to do. And finally, a few of them will be allowed to create the T-graft. Why is that the most protected anastomosis? Well, because if they mess that up, they've messed up the whole operation. And while occasionally we can cut that out and put it all back together and rebuild a T, they've jeopardized the most important aspects of the operation. So this is the sequence in which I try to train the residents in all arterial OPCAB. But that's a one-on-one thing, and others have been working in ways that have a greater impact on more people. And I think especially of Paul Sargent and his partnership with Medtronic. Paul is one of the Lifetime Achievement Awardees from ISCAS in the past. And he has this remarkable online community and teaching modality that you can see there at campus.meplis.com. I really encourage you to go there and have a look. It's a remarkable piece of work that he has done, funded by Medtronic. I saw some other interesting work at the training academy here at our 10th annual ISCAS meeting on Thursday. A company called Your Anastomosis actually does 3D printed models of your patient, so that this is case-specific simulator training and then manual training down in the space of that actual patient, which I think is pretty cool.
This was actually very cool.
I hadn't seen anything like it until Thursday, so I begged a couple of slides, and here they are. Now, we also met the London School of Cardiothoracics, which is a group of consultants and registrars here in England who are focused on improving teaching in cardiothoracic surgery. And their faculty mentor is Alex Cipollini. And I've asked Alex just to come and tell us very briefly what they do and how they do it, because I think this is something that could be expanded around the world. We could have organizations in many cities around the globe doing the kinds of things that he's doing to advance the training of young coronary surgeons. So, Alex, you are here, I think?
Yes.
There he is. Please
He's here
come.
on the left.
Good afternoon, everyone. Thank you very much for the very kind invitation for our group to join you. It's a big honor for us to be here, and I want to give a big thank you for the faculty and the Congress for this invitation, especially big thanks to Professor Puskas, to Gianluca, and to, obviously, David Taggart, who I've known for a long time. This meeting is phenomenal. It's shown everyone the latest evidence for coronary revascularization, the latest techniques, the latest sophisticated equipment and tips and tricks of how to do things. And it's very much state-of-the-art. What we have to strive to achieve as coronary surgeons is the pinnacle of our career. I think we recognize this, that coronary artery bypass graft, surgical revascularization, has to be seen as a specialty in itself. If you want to do it properly, you have to achieve the standards which have been described over the past 2 or 3 days. From our point of view, we are very much on the other side of the equation. We have set up this London School of Cardiothoracics, and we started about 5 years ago when we're in the COVID pandemic, and any training and education which we used to run with our junior trainees and residents stopped because we couldn't see each other face to face. And there was a big impetus from enthusiastic young trainees who wanted to get a career in cardiothoracic surgery in the UK to initiate some sort of academy where we can train the juniors at the very, very early stage of their career. So our target audience is year 1, year 2 residency, young surgeons who want to apply for cardiac residency programs, and even medical students who haven't had any experience in cardiothoracic surgery until they come and see us and join us with our meetings. And the only reason why we're here is because we have some very enthusiastic younger surgeons who are sitting over there, and without their help and their support, we're not going to be here. Their enthusiasm and especially their knowledge of social media has really helped our development over the last 5 years. So just very briefly to give you an overview of what we do, we're really going for a very basic training course. So over the last 5 years, we started off with very few basic surgical skills courses. We want to take juniors who are just starting their surgical career, or even not even done any cardiac surgery before, to have a taste and experience of what it's all about. And we want to teach them some very basic surgical training techniques, both in cardiac and in thoracic. We also engage them with the management of the cardiac patient. I think it's really kind of fundamental. They need to know how to optimize their patients before surgery. They need to have some knowledge of what they have to do in theatre to minimize the risk to the patients. And they also must have an idea how to manage a patient post-operatively. So really our focus is to look at more holistic education of our juniors, where, number one, you become a good doctor, and once you become a good doctor, then you can go and improve your specialty in cardiac surgery. Eventually, you will come to a stage where you can learn from the Congress and the world leaders in this institution here how to do very sophisticated, technically challenging procedures. So in the first year, 2020, we had 3 courses, and we thought we did quite well. And every year since then, we've increased the numbers. And because of our online presence, we've gone beyond London, and we have got interest from people who are coming outside London, from the rest of the UK, and we've had some interest from overseas people, students who have also joined us at this stage of their career. This is last year's academic year. We've about almost 200 junior doctors have come through us, and we are very much a not-for-profit organization. We're very fortunate to have some support from industry, and we try and keep the cost of our day teaching sessions to a minimum. Unfortunately, it's not entirely free, but the price is very, very low. We focus on lectures, practical sessions, and on some case-based scenarios where I quite enjoy doing those. We have a real-life patient from a few weeks ago. We discuss their presentation, we look at the investigations, and then we make a judgment call. What we're going to do with this patient? That's your patient. What are you going to do there? I want my junior colleagues to feel that when they have a patient who comes to them, they have to adopt that patient as their relative for a week until they go home. So they will do everything they can within their ability to make sure they go through smoothly without any complications and without any problems. So they need to know more than just technical skills. They also need to know some basic medicine and basic intensive care training. I think that's quite fundamental to our thinking. We do some simulations, and simulation is the key. I don't really want any one of my very junior trainees to come and have a go at the Lima to the LAD because it's an easy anastomosis. They have to show they can do the anastomosis in a simulation before they'll be allowed to come and do this in the real patient. So here we can see on this slide here, we have some chest drain insertions. We're very fortunate we have some engagement with Professor Saint-Jean, who came over to us a few weeks ago to help us with one of our courses. As you heard earlier, he's a phenomenal tour de force, and his involvement was really quite invigorating and stimulating to everyone who attended that course. And I hope we can continue our cooperation in the future. We also do some wet lab anatomy, and I'm sure you may or may not be surprised that I find that the junior doctors who want to do cardiac surgery, their cardiac anatomy is really quite poor, and it's quite interesting and surprising that they actually, when we demonstrate the pig heart anatomy, certain things which can relate to what you do in theatre and how close certain structures are to each other, they don't appreciate this until they've actually gone through this course. This is the cardiac component. Sasha Stimankovic is our robotic trainer. He's a thoracic surgeon, and his focus is mainly on robotic training in the UK. He's the lead robotic trainer in the UK, and I'm very glad that he's joined us as well, because from his point of view, he's got some very good simulation techniques, which he's trying to teach the junior doctors. And I'll let Sasha come up and just finish his talk off. Thank you for your attention.
So London School of Cardiothoracic is focused at young surgeons before their higher surgical training. And we moved into digital surgery training a little over 5 years ago. Big tech at the time, and still are looking at the consultant level, maybe the senior registrar level, as the people to focus on. And we clearly believe, Alex and I, as founder members of LSOC, we believe that we should be moving that level down and down and down. We've had 100 medical students come through on a Saturday, and they have all been on the robot. Similar numbers from the national young surgeons, again pre-training, they've come to our robotic courses. And it's a recognition that they bring with them as younger people. They bring skills to us as well as us to them. We're showing them computer-aided technology, and we're looking at their hobbies in particular. Our research has been looking at their musical talents, looking what type of musical instruments they are playing, what level of musicality they get to. Similarly, their gaming skills, what sort of gaming they're doing. And that's where our research is focusing at the moment. We're looking at their VR recreational versus their VR simulation skills. And we are actually scoring them using the analytics that come with that robotics. And we have presented at ASIT, which is the Association of Trainees in the UK. We've looked very clearly at all of their simulation. We think we're pitching this at about the right level. We are looking forward to 2025. 2025 will bring more courses. As you've seen, we run between 7 and 12 courses a year. We'll have continued industry sponsorship. We will go a little off-piste from a coronary conference. We'll go into an area where people are uncomfortable. In thoracics, that is open surgery, because we've gone completely minimally invasively in thoracic surgery. We will hopefully continue our excellent collaboration with Paul, with his coronary courses and other courses. We've been asked to franchise as a CALS course provider. That's the Cardiac Advanced Life Support, essentially reopening after disasters. And we're hoping to start a postgraduate certification in cardiothoracic surgery, again, aiming at the young surgeon. Once that is in place, we're looking to take our training outside of the UK. We want to take what we have learned over the last 5 years, and in collaboration with CTSNet, we're going to approach, first of all, sub-Saharan training centres and move on into India and South America. Basically, we want to allow the next generation to come prepared to start their higher surgical training in a better place, both in cardiac and thoracic, using digital skills. And on behalf of LSOC, Alex has sat down, but on behalf of Alex and myself and the team beyond, thank you very much for giving us this platform.
Fantastic, and I mean, we hope as ICC that this is just the start of a beginning of a long collaboration. It's our aim to advance coronary, and that means also to make sure that the next generation of coronary surgeons is well trained and well disposed. And thank you so much for all of you for being come here and the work that you have done. We move forward, and I will.
Yeah, Gianluca will present next.
I will go very fast. Yeah,
Very fast.
I will do one slides. We do like this. The topic is how we can make robotic the future or the present, TCAB. the reality is that robotic CUBG, it's a component that is growing fast. And there are several things that we need to make it reproducible. Yes, technique, technology, industry support, we have heard this morning, stabilizer, robotic stabilizer, and an anastomotic connector, multiple staples. We need a company that wants to take this stuff seriously and embrace the coronary bypass grafting, or better, the cardiac surgery as a whole. And reality is that for companies, cardiac are always like small numbers respect of hernia or prostate. But there is a patient value that cardiac brings that no hernia can bring to that specific company. Second is that we still have a lot of non-convinced heart surgeon about this robotic. And it's a pity, because the reality is that robotic is not here to compete against the sternotomy, is not here to say we are taking all of the sternotomy away. We are here to say there's a lot of patients that get assigned to multivessel PCI and should receive at least a mammary, if not 2 mammary. We are here to say if patients is above the age of 80, or if patients has high comorbidities, instead of giving a sternotomy, if you can give him 1 or 2 mammary artery with his chest close to the best target to the left side, and if the burden of the disease is not too bad, you might consider a less invasive. We are here to say we need coronary artery bypass grafting specialists capable of performing everything. My practice in coronaries is 250 cases. I perform 50% robotic, and the other 50% is sternotomy, and sometimes I do total arterial anaortic of pump. I did my first GIA, and I want to thank some of my Japanese friends. I called them the night before in a 4-time reduced sternotomy, and I was able to avoid the sternum and open the abdomen. And sometimes I do a mammary and 2 veins, so hoping for the best and bringing some sterile holy water, hoping that the patient can make it. I've done some very selected impella CABG of pump for patients with complex EF. We need people capable of performing more than one thing. I'm not a robotic coronary surgeon. I want, or I aim to be an expert in coronary artery disease, capable of performing every type of disease. The game is this one. These one are some of the mid-CUBG, great surgery, robotic-assisted mid-CUBG, small incision, all beautiful. Reality, though, is that you are landing an helicopter on a single helipad, okay? And the reason is like when you do your thoracotomy, the mid-CUBG basically allows you to do one single vessel, lima to the LAD. That is not bad, it's great, it's fantastic. A lot of patients can benefit. But TCUB, the real value is that move completely away the concept of limiting yourself from the space of the thoracotomy. My skin incision, have you seen, was small, but underneath the thoracotomy are always big and the patients have pain. Secondly, if you want to go to the lateral wall, this thoracotomy becomes bigger and you are pushing the heart to bring the view of that OM that is very deep into the view of your thoracotomy. Third, when you start to do some of these America McDonald aficionado patients with a BMI of very high BMI, it's not easy to do a mid-CUBG. Like you pass through a lot of tissue, and it's not easy. TCUB removes all of this. So let's pass through all of this, and I'll show you what I've done. I basically, in the absence of a stabilizer, included a Nuvo retractor inside a gel point mini and use the air seal system. This is what we came up. You see, this is the Nuvo retractor through a gel port mini that is inserted in a subxiphoid through a 1.8 centimeter skin incision. This is how I prepare it, and I go very fast. Gel port, and then I pass, basically, let me show you here, and I pass the Nuvo, and then I attach the Nuvo. And then you see that the CO2 line of the Nuvo is passed through one of these, you see my, and then take down of the mammary. Usual I skeletonize because I like it. You do what you want. And then subxiphoid. I enter down here. You see it's a 8 millimeter. You see that this is a 12 millimeter, 15 millimeter, and I insert this trocar and I deploy, give birth to the Alexis retractor here, boom. And then I insert the Nuvo with all of the gel point that snatch on that Alexis so you don't lose CO2. That's great. And then you deploy it, and this is the view. And then we finish. Look, this is the view that you have. I mean, everyone can sew this stuff. When you have a good view like this and you stabilize and you're comfort, this is the case, this is my number 9th case, I think. And you know, the case like take me a 2 hour and a half, 3 hours, skin to skin, just because someone is obsessed with timing. I'm not. But you know, the reality is that you can do it efficiently, and you can start to go to the lateral wall. And the stabilization of the lateral wall is not pushing the heart; it's just putting the stabilize to avoid too much movement of your heart, and allowing you to sew with calm, with precision, with perfect view, with very good understanding. Don't break the stitch, otherwise it's always a mess. And just, I do this double shunt to make sure you don't back wall. I have another, generally my fellow is on the other console, and we talk a lot. Do you think you like the stitch? There is Amanda, most of you met her. She's my surgical assistant, and she's my boss in the OR, and if the stitch is not Amanda proof, I have to retake it. And that's it, and you get, we have done now 22. This is another anastomosis, not as beautiful as the previous one, you see? Maybe a little bit of undersize of the shunt, some bleeding. Like not everything is video proof, okay? I'll show you real deal. Not everything is perfect, but you go slow and you get it done. Sometimes you move a little bit the shunt and you find the right way, but you are absolutely sure that you see every stitch. And I can tell you that something is what you see in 2D, like here, when you are in the 3D of the robot, you see much, much better. So not everything is like, but you see, this is, you remove the bulldog, you pass you pass your TTFM, and you're good to go. These one are all good patients. I'll show you this one. That's the only patients I want to show. I don't know if we have some sound.
What my apprehension was, my remembering of my experiences training at the Cleveland Clinic and people undergoing open heart surgery. And you made me feel very relaxed with our preoperative visit and with the anticipated procedure that you wanted to perform. And I felt very confident with my colleagues telling me of your ability. I think referred to robotically assisted. I was able to do 3 laps around the nursing state arterial lines, and the IJ line was removed. I felt very comfortable. I was able to walk in the hallways on the surgical floor, on the post-operative floor. I was able to do 3 laps around the nursing station, which was a couple hundred feet, and I didn't have much discomfort whatsoever. I could breathe pretty readily, easily, didn't have any chest discomfort breathing. I think on the post-operative attempt to use the incentive spirometer, I got it up to 1,500 at that point. And over the course of the week at home, I've been able to bring it up to 3,500 pretty easily.
How many weeks we are from surgery now?
I'm 10 days out of surgery.
Wow, fantastic.
Yeah,
And do you feel great? Pain? Have you had pain during this time? Do you have?
I should use it because I want to stay ahead of the pain, but in these last 5 days, I've hardly used that. Uncomfortable than this procedure. Yeah, just right from the beginning.
What you were telling me about the dental procedure. In terms of
I've
pain.
had dental extractions that were more uncomfortable than this procedure.
I think that as a patient, is a cardiologist training Cleveland Clinic, discharging postoperative day 1. We have done now 22 cases. I'm sorry, I don't have the slide, but we have done more than 20. We are presenting in STS our 22 cases, and we propensity match with the robotic mid-cubs, showing a reduction in cost and more multi-arterial in a T-cub rather than mid-cubs. This is the way in which we need to think, and I think that there is a role for it. We need training, education, we need support from cardiac surgeon and support from the industry. Thank you.
Yeah, thank you. I also needs a strong voice from patients, as we just saw. I think they're the advocates of many invasive procedures, and we should give them more room, actually. Yeah. Also at meetings like this one, just as a thought, maybe.
We actually, it's a great thought, and we actually thought to bring here a patient of mine who is a television presenter, and
bring him
we
next
will do it.
time.
Next in New York, we will do it. I want to introduce Dr. Volmar Falk, who is giving the last talk of this 10th Annual International Coronary Congress. We have debated a lot, and we have heard a lot this concept of coronary as a subspecialties. He will give us his point of view as chairman in Berlin and president of the European Association of Cardiothoracic Artery.
Yeah, thank you very much again for the invitation to this meeting. And there's few people left, but maybe still interested, so I try also to be short. One thing that we all know and learned over the last years is that high volume and subspecialization somehow lead to better outcomes. And this is largely related to the fact that whatever we do, is it playing a music instrument or doing anything, playing football, with more practice you get better, and with more games you play you get better, and it's a mix of technique and experience that over time you produce higher quality. And I would just take the opportunity to go outside the coronary field also, so that your minds get a little bit more liberal this afternoon again. To show you some examples where we have very good proof of this connection. This is the STS database, 50,000 patients, 800 hospitals, 2,500 surgeons. And this is the mortality by 6-year volume. So it's a little bit strange measure, 6-year volume, but what you clearly see is that between the centers with, between the centers who do less than 10 and those who do more than 50, you almost have 4 times the mortality. And this is also visible here, conversion to valve replacement, it's 5 times higher. And just to give you an impression, at the German Heart Center, our 6-year volume is here, and this is our outcome. So at some point this becomes flat, this curve, but certainly if you think about a hospital where you want your operation, you don't want to go in a place like this. So this is the mitral volume that we have. We do all these procedures minimally invasive, as you know, periareolar incision, endoscopically. I'm not showing you the whole case, but what I would like to share with you is the observed versus expected mortality. You see here the STS risk, which is 0.8. It's a low-risk population, obviously, but the observed mortality is 0.3. So, and that with a repair rate of 98%. Similar in TAVR space. Also here we have a volume outcome relationship. This is our program right now. This year we will do about 1,300 cases. Pretty much standardized, and this is the mortality, 1%, but if we compare this to the nationwide database, and this is a mandatory quality database, you see that the observed versus expected is way below the country standard. And that's because we have a very specialized team. For the mitral space, it's only 4 surgeons who do the mini mitrals, and for the TAVR, it's similar. It's 2 surgeons, 2 cardiologists that basically do this volume of cases. Now, what do we know for CABG? These data are a little bit older, but you see on the left coronary bypass grafting, and here we're talking about hospital volume, so institutional volume, and you see that there's a clear relationship between the number of cases that are done and at an institutional level and the mortality, and that is also true for surgeon volume, similar relationships. So there's of course somewhere a threshold, but until then an increase of quality with more case exposition. This is more recent data from Taiwan, 13,000 patients, and you can see and notice that in this area it's more or less a lottery what the results are. So in the very low volume centers, the results vary a lot. And I think it's not only the fact that the results with more experience get better, but also the variation of results seems to decrease. In the low hospital, you will always find good people in small hospitals, but you will also find bad performing people in small hospitals. And that's why you have this large variation. And for the larger centers, this largely goes away. This slide you all know, we have seen it multiple times. Why I'm showing this? It's because it's not only mortality, which is a quality outcome, it's also, as we know, the conversion rate here, in this case from in a randomized trial where patients who were planned to get both memories only received one. And the rate at which surgeons converted varied also with the number of cases they were doing. And you see that again, a similar pattern here. Of course, there are surgeons who can do very well with small volume and participated in the trial and were able to provide patients with betas. But there were others who didn't even care. They were just converted right away. So it has something to do with exposure. Now, how does it look with on versus off pump? This is 2 million patients. It's almost the biggest, I think, group I've ever seen in a paper, 2 million. And here we're talking about surgeon volume in black and hospital volume, and you see the quartiles. And the question here was, when is off pump better than on pump? And we discussed this earlier this afternoon already, especially in the poster session. And you note that only when you do high volume in the in the fourth quarter here, which is the high volume quarter, then you have an effect on surgeon and hospital volume. And off pump actually, which with one or with more grafts becomes better than on pump. So it's clearly a matter of experience, and it's a matter of volume. And that explains also the differences in these trials, in the earlier trials where people had no experience, obviously had problems with doing off-pump procedures. But still, I mean, you have to think how you can transition your own hospital into the fourth quarter here to make it really efficient and beneficial for patients. Now, the guidelines in Europe, at least, for the first time in 2018, adopted this thought and said, okay, we have to somehow put out a number. And I have to submit to you that this number, which is here the annual institutional volume that institutions that offer CABG should have, is 200 cases. This is a completely erratic number. I mean, there's no science behind it. There's no, that's why it's also level C. It's what the people in the room thought at the time is a reasonable number for the number of cases for a hospital to offer CABG to its patients. And we can argue about this a long time, but at least finally we got a number out, and that tells you something, because typically these guideline recommendations are very conservative and tend not to put out minimum case numbers. So that was really a new thought. And I think also, David, it's partially your initiative back then that we came up with a number, and it's actually written there. So what are the requirements for a successful CABG program then? And we discussed this also in various aspects. Obviously, over time, CABG outcomes have improved markedly. So when we now start a program or we look at our program, we have to look at the current benchmarks. And those are actually pretty strong. We have learned about the requirements for endoscopic competence. It's not only for robotic cases. It starts with endoscopic vein harvesting and endoscopic radial harvest. Before you sit down at a robot, get used to do endoscopy. And why not starting with a radial harvest, which gives you great training in using an endoscope altogether. And then, of course, we do have some guideline recommendations for arterial revascularization and some surgical techniques. And obviously, if you do something like this, a multi-vessel mid-cap or multi-vessel off-pump, be it with robotic or non-robotic assistance, I mean, we're facing limited access, beating heart, endoscopic harvesting of grafts. We want complete revascularization and fast recovery. I mean, this is something that is complicated, and probably not everyone should be doing it. We should certainly follow the thought that we need to subspecialize in interdisciplinary teams. And for the valve area, structural heart disease, I mean, this is pretty obvious. I mean, and we do it almost in every center. It's also true for aorta. At most centers, aortic surgeons have their own rooms, and do their own work. And I think that coronary shouldn't be any different of this. And this is beyond meeting with the heart team every now and then. So I would take this question mark out and put an exclamation mark. I think it should be a subspecialized area. Now, this is from a paper from a group in Maryland. They have thought about this and said, okay, what can we do to improve outcomes with subspecialization? And that was the scheme that they put out, and it has a clear leader who's mentoring also younger surgeons. It's about standardization of techniques and standardization of care and quality reviews. So all the elements are there. Standardizing the technique, the care, and the quality reviews. And when they looked at the outcomes, it seems that this program is actually successful. So they compared the two eras and note that all these measures have improved. So the cardiopulmonary bypass time, cross-clamp time, skin-to-skin time, the use of two memories, intraoperative blood perfusion, all improved with subspecializing CABG. Also, there was a signal for better observed versus expected mortality, although this wasn't significant due to the small numbers. Today, I would add, and after what we learned on this meeting, again, we have to put more things in this. And starting with the team leader, I put out the director. It doesn't have to be the director. I think it has to be someone with dedication. I think it's important that the team also develops the knowledge about evidence-based decision-making and heart team competence. I think it is part of our duty that we are informed when we go in heart team meetings. And so often it happens that our cardiac surgeons do not know the literature. They don't know the small print, and it's difficult to argue. So that is something I would submit to you is necessary as a part of the subspecialty. Then, of course, the standardization of care is not only about the operation, it's about prehabilitation program, ERX program, and also competence in imaging. I mean, most of you will look at CT scans, but who is able to do 3D reconstruction himself? You don't have to raise your arms, but I put the question out. And I think that is a competence, if you do coronary surgery, minimal invasive, you should have. I mean, you need to be in the driver's seat, not only with your scalpel, but also with your radiographer. Now, quality review is nice, so if you have a good benchmark in the STS database, I envy our American colleagues because they have it. We don't have something similar in Europe or in Germany, but what you can do on a local basis with your own team, you can do a QSUM analysis, and I'll show you that. Now, prehabilitation is something that has been discussed, so our care and the coronary care starts earlier by optimizing the patient's correct anemia, optimize antidiabetic therapy, stop factor 10A inhibitors, and so on. The pre-surgical outpatient visit, the patient was just referring to it. I think it is a very crucial element of the treatment to actually talk to the patient up front and set the expectations right. I think that is clearly something that this patient just confirmed, helped him to be more relaxed, and the relaxed patient has a better chance to survive the operation. Now, the ERAS concept, of course, starts with early extubation, early physiotherapy, and early family contact, and avoidance of the ICU and a pulmonary artery catheter. I mentioned this already, right? So we don't want any invasive measure that the patient don't need. The training should be competence-based, and we saw just good examples on how to approach the training by a stepwise approach. I think that in residency programs, an early adoption of off-pump techniques should be mandatory. The earlier you learn that, the easier it is. I think it doesn't make sense to spend 100 cases on pump and then go off pump. I think it's good to start early with this. And then when we do a training program, it's not what I think is best for the patient or you think. We do have guideline recommendations for what is best for patients. And here's a list of things that we need to integrate in the training, which is minimizing aortic manipulation, off-pump for certain risk groups, complete revascularization. It's all here, 1B recommendation. Of course, quality control, graph flow measurement, endoscopic vein harvesting, use of bilateral IMA under certain circumstances, skeletonizing radial artery use. I mean, all these things are in the guidelines, so it's mandatory somehow that we actually adopt them in our programs and teach them also in order to make the guidelines living guidelines. And if you're looking for benchmarks for your own program, you may look at the FAME 3 outcomes. This is 1 year follow-up, not talking 30 days. It's 1 year. Mortality for CABG, 0.9% after 1 year. Yeah. I think that is a contemporary benchmark that a program should work against. Cardiac death, 0.5% after 1 year follow-up, and stroke, 1%. So that is something to keep in mind when you look for benchmarks. Now, as I said, we did this a couple times, and this is just an example that we published a long time ago when we looked at surgeon performance. So these are all surgeons learning mid-cap, and you see that there's various talents. So this guy is leaving the confidence interval very early. These are 2 high performers, and here this is more or less average. They go with the expectations. So and the question is, when you see something like this, you would probably invest in this guy. He could become eventually someone of these guys, and this is then the group that should be doing the subspecialty of coronary surgery. I think you can actually manage to objectively find out who can actually do this in a very proficient and well way. And this all is not my idea. It all is written down many years ago. And again, you see David's name here, who has put this together with Michael Mack. And I take this one quote: a really definite and good accomplishment is today always a specialized accomplishment. And I think that is very, very true. And if you want this outcome, which I think is what we are looking for, arterial grafting multivessel with good patency, then I think there's no other way than subspecializing. And with that, I would like to thank you.
Fantastic talk. I leave the microphone to Dr. John Pascas for the closing remarks.
I frankly cannot think of a better closing lecture than that. Thank you, Volkmar. Volkmar is a member of the board of directors of the International Society and leads the biggest center in continental Europe. I thought your perspectives on coronary surgery as a subspecialty really put the final exclamation point on what has been a great scientific program for the last 3 days. Thank you.